Welcome to the CGA-IGC podcast series, brought to you by CGA's Education Committee and made possible through the generous support of our sponsor, the King Center for Lynch Syndrome at Penn Medicine's Abramson Cancer Center. Each episode of CGA's podcast series provides an in-depth discussion related to emerging data, clinical challenges, and unique perspectives in the world of hereditary GI cancers. Before we start, we'd like to remind you that the content of this podcast is not intended to replace professional medical advice, diagnosis, or treatment, and the content reflects expert opinion at the time of recording. Keep listening to find out more about this episode's host, guest, and featured topic. And be sure to learn more about our sponsor at www.med.upenn.edu/King Center.
Welcome back to an episode of the 2026 CGA-IGC podcast series. My name is Josie Baker, and I am a certified genetic counselor at The Ohio State University, and I will be your host for this episode. During this episode, we will be speaking with Dr. Jennifer Weiss, a gastroenterologist from the University of Wisconsin, Rachel Hoden, a certified genetic counselor at Stanford Healthcare, and Dr. Samir Gupta, a gastroenterologist from the University of California, San Diego. Dr. Gupta is the chair, and Dr. Weiss is the vice chair for the National Comprehensive Cancer Network, Colorectal, Endometrial, Esophageal, and Gastric Cancer Guidelines, and Rachel is a panel member for NCCN. Today we'll be discussing the most recent update for NCCN on Genetic and Familial High-Risk Assessment, version 1.2026, for colorectal, endometrial, esophageal, and gastric cancers. Thank you all for being here today.
Thanks so much for having us.
Thank you.
There's a lot to be excited about with the newest version of these guidelines, and I'm looking forward to talking about some of these updates with you all today. One of the first changes that I wanted to just talk about is that multigene panel testing is recommended for all individuals with colorectal, gastric, and endometrial cancer, regardless of age. However, for colorectal and gastric cancers, testing ages 50 and above comes with a Category 2B designation. And just for a reminder for our listeners, Category 2B is defined as, based upon lower level evidence, there is the NCC consensus, which includes 50% or more, but less than 85% support of the panel, that the intervention is appropriate. Can you all walk us through if this designation changes anything, or are most people going to be offering genetic testing to all individuals regardless of age for colorectal, gastric, and endometrial cancers?
Yep. Thank you, Josie. We really have been grappling with this question for many years. Who should be offered multi-gene panel testing, and should it be stratified by age? In this case, to me, the 2B recommendation is really around the consensus. And that when we had a panel, it indicates that when we had a panel vote on the issue, that fewer than 85% of people voted yes, but more than 50% did. That's sort of where it's coming from. And I would encourage all the listeners to know that we revisit these questions, especially the 2B recommendations, every year as part of our panel discussions. So it's very likely this will come up for a vote again next year, and it may evolve. So that's just something to know. In terms of why there was not consensus, I can give you my take, and Dr. Weiss and Rachel can give you theirs. To me, I think there's a couple things. One is there's still concern about whether we can deliver this volume of care. Do we really have the care pathways? I think all of us understand that we can't have this be genetic counselor driven to initiate testing if we want to deliver this. So there's some concerns about that. There are still some people who would like to see more data, or maybe some less biased data, about what the yield is in older ages, and especially looking closely at the yield for what. Often people will bring up, clinically actionable genes, where the definition is that NCCN said something about that gene in one of its guidelines. Personally, I don't think that's the right bar. There are some people who are very interested in seeing, for example, how often are you going to find a colon cancer or colon polyposis associated gene if the reason you're doing the testing is related to a history of colon cancer. So those are my thoughts in terms of, does this change anything? I think for people who are in a position to offer genetic testing across the age span, I think this should give them the freedom to do that. For people trying to make decisions about whether they want their screen for Lynch syndrome to be driven by germline testing versus immunohistochemistry or MSI, that's of course not taking into account whether it matters for treatment, then this also gives them the option of doing that to me.
Yeah, I think that really covers a lot of it. One of the things that drove this is the idea that for a long time, we've been recommending universal tumor testing for all of these cancers, for endometrial, colorectal, gastric, all Lynch syndrome associated cancers for quite some time, regardless of age. But then recognizing that that's a stepwise approach that's complex and cumbersome. And for some people, there's an opportunity that we lose people along the pathway to go from that to germline testing. And then in addition, we always review the most updated literature. And there was a new study that was published that showed the cost effectiveness of germline multigene panel testing for colorectal cancers upfront. And that's relatively cost effective compared to doing that universal tumor testing. That was just kind of another step that led us towards the upfront recommendation for upfront multigene panel testing for the colorectal cancer, endometrial cancer, gastric cancer. But yet the age distinction, I think, really comes from the fact that, as Dr. Gupta said, the concern about the lack of data for the yield of this testing in older adults, especially with gastric and colorectal cancer. And I think that concern kind of comes across in multiple areas within our guidelines, even with polyposis testing, that the recognition that the yield is a little bit lower for people who are presenting with multiple colorectal polyps at a cumulative age of 60 or higher, the yield is a little lower than for people who are presenting with 20 or more adenomatous polyps at an age of 30 or 40. So just this idea that we recognize there is a spectrum of yield depending on age, and allowing people to do this if there's an opportunity, but also kind of have the freedom to use their clinical judgment depending on that person sitting in front of them and their personal history and their family history.
Yeah, and I'll echo and expand a little bit on the access question, because I think Dr. Gupta's point about our ability to triage all of these patients with traditional pretest models, we know that that's just really unsustainable. And I imagine that a lot of high volume centers, including ours, are strategizing about how to provide appropriate guidelines-based access. And so we know that there's a benefit to having these updated guidelines to allow for better coverage access when they do present to our clinic, especially in the setting of limited family history or other barriers to risk assessment. So that becomes really important as well. And I think that is our next kind of challenge, is how do we then provide greater access to all of the patients who are now kind of under this guideline umbrella.
Thank you all for your insight. It's very helpful just to hear the thought process of panel members and people on the committee who are making these decisions. And following up, the guideline now provides separate risk tables for EPCAM-3' deletions with MSH2 involvement versus without MSH2 involvement. For deletions extending into MSH2, the cancer risks are on par with the standard MSH2-associated Lynch syndrome. However, for EPCAM-3 deletions without MSH2 involvement, the colorectal cancer risk is now listed as 75% chance throughout the lifetime up to the age of 70, while endometrial cancer risk drops to 12 to 25% chance, and then gastric cancer data is now described as minimal but suggestive of an increased risk. We know that there have been early reports that have shown these two were phenotypically different. So one of my follow-up questions is, what drove these guidelines to shift now? Has there been new data published that further support this phenotypic difference, or did this result from a re-review of older publications?
This has been something that we've been kind of contemplating doing for quite some time on the panel, and it wasn't necessarily due to any new data, but it really was recognizing that it was prior data that showed that there was two kind of phenotypically different presentations for individuals with the EPCAM deletion, depending on whether MSH2 gene was involved. We recognize that the data is smaller studies, smaller populations, but that it was compelling enough to show that these individuals should be potentially treated differently and managed differently. And so we did want to make sure that that nuance was now represented in the guidelines. But I think also the hope that this would spark potentially more future research for people to really pay attention to the fact that we need to call out EPCAM-associated Lynch syndrome in cohort studies, and that we really need to also try to analyze depending on the location of the deletion. So I think it was both a re-review of prior literature, which we recognize is limited, but also the call for future research in this area.
That's perfect. It's right on. And I just underscore for our panel, and I've seen it happen in other guidelines, calling out when there are lack of data is really an opportunity. And at least I've seen time and time again, when we make changes like this that call out an absence of evidence, a lot of times within 2 years, all of a sudden we'll start to see some papers and some additional useful information come out. So we'd love to see some papers really focusing on EPCAM and distinguishing between those with and without deletions that extend into the MSH2 gene.
The guidelines now include revised wording around opportunistic salpingectomy for Lynch syndrome patients. The guidelines now state that this has been shown to reduce the risk for ovarian cancer in the general population, is an option for premenopausal patients with hereditary cancer risk who are not yet ready for an oophorectomy. However, it adds the important caveat that there is insignificant data regarding efficiency of the salpingectomy alone for the prevention of Lynch syndrome-associated ovarian cancers. Can you please discuss why this distinction matters for our population?
A great kudos to our gynecologic oncology colleagues who work on our panel, really dedicated to making sure that we are appropriately providing recommendations within the scope of Lynch syndrome. And of course, recognizing that the hereditary breast, ovarian, pancreatic, and prostate cancer guidelines also dedicate to making sure that there's good recommendations for ovarian cancer prevention. We were really thoughtful about the nuance of the data lacking for non-serous tumors. And so while there's great data that it is good risk reduction for serous tumors with salpingectomy alone. So thinking about stick tumors that develop in the fallopian tubes and making sure that we're providing a highlight around like whether or not that's the same or different for Lynch syndrome-associated ovarian cancer. Majority of patients who have Lynch syndrome-associated ovarian cancer will have a non-serous tumor. So important not to overestimate this unknown impact on risk reduction in that particular population with salpingectomy alone. Really important for patients who may not have access to a gynecologic oncologist. So patients with Lynch syndrome who can work with their particular treating provider, whether that's a general gynecologist or other type of provider who can advise them appropriately when they have access to these guidelines, and hopefully they're kind of reading through carefully. So I think great distinction, and also a great thank you to the gynecologic oncologist on our panel.
We definitely appreciate all of the expertise we have from the gynecologic oncologists on our panel. A lot of us are gastroenterologists and colorectal surgeons and genetic counselors, and this is an area that we want to make sure we are providing the most up-to-date recommendations on, and we rely very heavily on their expertise, and it's very much appreciated.
And then to wrap up our Lynch syndrome discussion for updates, there has been some confusion in the field about the absence of PMS2 from the recommended gastric cancer multigene panel testing. The guideline lists the minimum gastric cancer panel as APC, ATM, BMPR1A, BRCA1 and 2, CDH1, CTNNA1, Lynch syndrome genes including MLH1, MSH2, EPCAM, and MSH6, PALB2, SMAD4, STK11, and TP53. But PMS2 is notably absent. With this, the guideline does note that the panel recognizes that not all of these genes have been definitively linked to an increased risk of gastric cancer. Can you explain the rationale for the omission of the PMS2 gene? Is this because PMS2 has not been definitively linked to an increased risk for gastric cancer, or is there another reason?
I'll ask Dr. Gupta to also weigh in on this because he was on this subcommittee as well. But yes, I do think it is because there is no definitively increased risk of gastric cancer with respect to the association with the PMS2 gene. Now, that being said, the multi-gene panel testing, if it includes Lynch syndrome genes, people are going to be tested for PMS2 who make it into the guidelines through this pathway. Putting it into perspective, if we're worried about Lynch syndrome and somebody has a family history of gastric cancer or an early onset gastric cancer, and then other family members with other Lynch associated cancers, they're going to get tested for a PMS2 gene mutation due to making it into that testing pathway through the concern or suspicion for Lynch syndrome. But this is now our kind of second section of if you're making it into the testing pathway because of gastric cancer and maybe family history of gastric cancer and not necessarily that first suspicion of Lynch syndrome. So if you're making it into that testing pathway that way, then the PMS2 gene is really not a gene we're that concerned about based on the data. And I'll have Dr. Gupta add any additional comments on that.
That's right on. I mean, the only thing I'd add again is just a call for research. One of the most common pathogenic variants we see, and yet we have the least data on the natural history of what happens to the average PMS2 pathogenic variant carrier. And this is something that could change if a good cohort study does suggest that PMS2 is associated with increased risk for gastric cancer. Then we may end up updating this at some point.
And then shifting over to polyposis, the guidelines have also introduced a terminology shift, replacing colonic adenomatous polyposis of unknown etiology, we also know this as CPUE, to now with idiopathic adenomatous polyposis, or IAP. And Dr. Weiss also introduced this a little bit earlier, but with this shift, there also has been a restructure to distinguish patients with 10 to 19 adenomatous polyps who are now recommended for genetic evaluation from those who meet criteria for genetic testing with 20 or more colonic adenomas. Can you walk us through the practical difference between genetic evaluation and genetic testing that is clinically indicated? And how does this restructuring change the way we should approach care for patients with more moderate polyp burdens?
There's two interesting issues here. One is the terminology shift from idiopathic adenomatous polyposis. I think you'll see multiple colorectal adenoma out there, colonic adenomatous polyposis of unknown etiology. I think the idea here was to indicate in general, the conventional wisdom in medicine is if we say something is idiopathic, it indicates we've done some investigations and have not come up with an answer yet. And so there are some panel members who argued for this designation and everyone felt comfortable with it. So that's sort of how we landed there, is to really try to telegraph that this is after you've done your best workup and you don't have an explanation, that we want people to be called as having idiopathic adenomatous polyposis. And then the genetic evaluation versus testing, it's the genetic evaluation. What we're trying to signal is for a person with 10 to 19 adenomas, or any scenario where we say genetic evaluation, step back, take a 3-generation pedigree, think about whether there are any extraintestinal manifestations, for example, consistent with FAP, and then decide if you want to do genetic testing. And the contrast to that is where we say genetic testing, we're basically saying just we think this person should be tested, regardless of what other features they might have to go along with what might be on your differential diagnosis. So that's really the distinction here. I'm curious what Rachel and Dr. Weiss think, but what we are not trying to indicate here is that every person with 10 to 19 adenomas should have a multi-gene panel test.
And I'll just add to what Dr. Gupta was saying in terms of your best workup. I think idiopathic in this context, making sure that providers who are not as maybe familiar with a lot of the polyposis genes, especially kind of newly described ones, are taking note of additional genetic testing that could be done if, for example, previously APC or MUT-YH testing was performed and was negative, making sure that they can pay attention to additional recessive genes or other dominant genes that have more recently been described, and hope that those patients who are appropriate for that type of multigene panel testing are getting kind of updated testing. So to kind of call that out as well. And then absolutely agree with this idea of genetic risk evaluation could include a pretest genetic counseling visit, but also could be a really savvy gastroenterologist who realizes over the course of multiple colonoscopies, this person has more than 10 cumulative polyps, and having a conversation with them about other indications based on family history, as Dr. Gupta was mentioning, and then, shared decision-making about appropriateness of germline testing at that point.
That's exactly what we were trying to get at. And in addition to, I think what I alluded to earlier, just that idea of stepping back and taking into consideration the age at which someone presented with this cumulative number of polyps. And so that if somebody sits in front of you who's 75 years old and has just reached that 10 lifetime cumulative adenomas and no other family history, that this is somebody that you can talk to them and explain that the yield of genetic testing is likely very, very low, versus somebody who's presenting with their first colonoscopy at age 45 and you find 10 advanced adenomas or 10 adenomatous polyps and half of them are advanced adenomas, and they have a family history of an early onset colon cancer in a first degree relative. I would be way more suspicious for that person. And then my genetic evaluation would include recommending genetic testing for that person.
And another major addition to these guidelines is the introduction of a new section dedicated to hereditary esophageal cancer, which I'm very excited about. So within this, the guidelines highlight two key hereditary syndromes associated with esophageal squamous cell carcinoma. So tylosis related to RHBDF2 variants and Fanconi anemia. Can you speak on this decision-making process behind formally incorporating esophageal squamous cell carcinoma into these guidelines? And with this, could you also elaborate on the rationale for excluding adenocarcinomas from this hereditary framework?
Yeah, so I can start because I was on the subcommittee for this. The rationale for including this in our guidelines is probably not as exciting as I think most of the listeners are hoping. We were asked to take this on from the NCCN, and there are a number of committees where obviously there are potential hereditary reasons for those cancers, but don't necessarily have the genetic counselor expertise or the genetics expertise as part of their panel members. And so they do not feel totally comfortable being able to represent the most updated literature. And so we were asked to take over the hereditary esophageal cancer kind of recommendations. And as part of our review and trying to come up with these recommendations, we did literature searches and looked into both hereditary squamous cell esophageal cancer, as well as evidence for any hereditary esophageal adenocarcinomas. And we really just did not find sufficient data to recommend specific genetic testing for potential familial or inherited causes of esophageal adenocarcinoma. But there was for the squamous cell esophageal carcinoma. And so that's why that's really called out to a larger degree in these pages. Now, we do recognize that there may be considerations for providers who are seeing families with multiple family members or early age family members that have esophageal adenocarcinoma or early onset Barrett's esophagus in multiple family members. But at this point, we didn't feel that the data was sufficient enough to make significant recommendations in those settings. But again, this kind of sets us up for, now we have these pages, and now we will be making sure we're looking at the current literature every year. And if there's new updates, good studies, it will be added to future guidelines.
All right. And are there any other changes that we haven't covered today that would be important for the audience to know about?
I could bring up something that was very instructive for me was working with the pathologist on our panel to create some additional tables that describe the typical pathology that's found in gastric polyps in FAP. And I've found this difficult to approach. It was interesting to see the debates that went on between our pathologists about the terminology. And I think the end result is for people who are caring for FAP patients and managing their polyps and trying to figure out essentially which end is up, I think that's a useful thing to return to either after you've taken out the polyps or before you do an upper endoscopy in someone who has FAP. Both the basics of if you see a polyp in the antrum, it needs to come out because it's more likely to be an adenoma. And then on the back end, as you find various pathologies, what they really mean in terms of cancer risk and any need for follow-up intervention. So I was really impressed with the work that that subcommittee did on that section. They worked really hard on it.
Yeah, I agree. It's a really great addition to the guidelines, and especially as a gastroenterologist, like trying to explain to my colleagues that if you are scoping one of these patients, that there really are additional things that we need to pay attention to and not just assume that every polyp in the stomach is a fundus gland polyp. And I feel like after being on this committee for so many years, we spent a very long time really trying to get across the idea that fundus gland polyps with low-grade dysplasia in these individuals are expected, and that's not something to get up in arms about and send someone for a total gastrectomy because they have fundus gland polyps with low-grade dysplasia. But now we're kind of shifting also towards the fact that people need to know there are other types of high-risk polyps that can be found within these individuals in these stomachs that are carpeted with polyps, and that it really is important to pay attention to what you're seeing, what you're looking at, taking good pictures, taking biopsies of things that you're not sure what type of polyp they are, making sure that any polyp in the antrum is removed. This has been a really, really great addition to the guidelines, especially for, I think, practicing gastroenterologists.
The other thing I'd make a comment on is something that I feel like ended up being a nothing burger in terms of feedback. So we made major updates over the prior iterations around management of patients with CDH1 and leaving a lot of room for the idea of shared decision making, and that electing for surveillance instead of gastrectomy is a reasonable option. And I have to say, I was expecting a lot more chatter and comments around this, and we didn't see that. And maybe that's also reflective of people who are caring for these patients are aware of the data that's been emerging and the increasing uncertainty regarding our ability to predict who's going to be a progressor and who is not.
I'll just call out something that got commented on in some discussion around in my clinical group, the addition of more traditional breast cancer associated genes on our tables, highlighting the conversation around gastric cancer risk in some of the patients with, again, traditional kind of breast cancer associated genes, ETM, BRCA1, BRCA2, PALB2, and kind of recognizing that, again, the data are evolving and we'd love to see more work done in that area so we have better evidence to say whether or not those patients are indicated for EGD surveillance and kind of what that looks like. I took note of that kind of within the scope of seeing kind of broader indications in our clinic, which I'm sure a lot of our listeners do as well. If you have a patient with a BRCA2 pathogenic variant and there's a family history of gastric cancer, maybe already people were paying attention to that, but I think it highlights that we should be considering whether or not those patients would benefit from some level of surveillance, H. pylori testing at a minimum, for example. And so I think that created a lot of conversation within my clinical group.
Rachel, thanks for sharing that. That sort of just reminds me, we've been really fortunate to have a lot of engagement from all the people in the community who care for these patients. We get lots of comments. We get the comments that are put on the listserv get rolled up to us. And I just want to emphasize, we really appreciate it when there are discrepancies that are found. One of the things, as we list genes for which the primary management is really driven, for example, by the HBOP guidelines, we're trying to do our best to make sure that any comments we make about genes for which the primary management is in another guideline, that our comments are not different, our recommendations are not different and do not supersede. We really try to defer. But sometimes there can be some sequencing issues where one guideline comes out before the other, or some delayed communication. And so as people notice those, we definitely appreciate becoming aware of that, because our goal is to have the recommendations be consistent. And I think we have a pretty good system. For example, the HBOB will defer to us on Lynch syndrome recommendations, and we will never drive a BRCA recommendation. And we try to stay consistent, but if there's ever any inconsistencies that are observed, just let us know about it so that we can resolve it. That it is not our intent to create any discrepancies.
And to wrap things up for today, do any of you have any last take-home messages for our listeners about these updates?
Just say a really big thank you to Dr. Gupta and Dr. Wise for leading our panel. I think I speak for everyone else on the panel about how great of an experience it is to be a panel member, and the support of the NCCN team as well. So just a big kind of public shout out to all of them.
Well, thanks, Rachel. I would think I also would speak for Samir by saying that we also have so much thanks and appreciation for the panel members and for all the work that everybody does. I mean, I think people don't realize how much additional work everyone is doing in between the panel meetings we have to update the guidelines. There are many, many subcommittees and additional work that goes in, and our panel members are extremely engaged, and it's just a pleasure to work with everybody.
Yeah, every new page is usually like a year's worth of work. When you see a new page, that means that there were between 4 and 8 people who really spent a lot of their extra time in investing in those changes. So yeah, we definitely appreciate the engagement.
All right. Once again, thank you all for joining us for an episode of the 2026 CGA-IGC podcast series. For our listeners, stay tuned for our next podcast to come. And thank you for everybody today.